Perfect.
Okay. All right, so this is just a recap of a presentation that I did in May of last year. We started our CT colonography about that time, and since then we've probably done about another good 70 cases. I did 50 cases prior to that as part of the training. So the presentation is much similar. I have updated a little bit to get a bit more current to what we are doing at the moment. So this is a little video clip I took off the internet. It's unfortunately the resolution is not as good as it is with our own workstation here, but it just does give you an idea of what what the endoluminal view looks like. And there you can see that we're traveling through the colon, and you can see that polyp coming up there, and there we pass it, going through the colon again. So this is all computer generated. There's another polyp coming on. All right. Just watch that through again. So this is what we see on our workstation once we have done a CT colonography. We actually use both the endoluminal and 2D views to evaluate the colon. Let me see. Okay. All right. So there obviously has been a lot of research and development into the screening of colorectal cancer, and because of that we have definitely seen some positive trends over the years. Specifically, we looked at 1970 to 1990, and we have seen that the incidence has decreased by 7%, our mortality has decreased by 20%, and the 5-year survival rate has increased by 12%. So we are seeing a positive effect. But so just to give you an idea of what colorectal cancer does, it has a lifetime risk, 1 in 5 or 5% or 1 in 20. Risk for death is 2.5%, a little bit more common in males than in females. And just an average risk person has about a 75% chance of developing the disease. So despite all these efforts, we're only having a limited impact on the cancer. About 40% of cases, only about 40% of cases are localized by the time of diagnosis, and 20% will already have distant metastases when they are diagnosed. And we see this. We see patients presenting with metastases, and almost the first thing that we do is we go and look at the colon when we're doing a CT exam. So what are your risk factors? Well, the older you get, the better your chances of getting cancer. 90% of the ones that we diagnose are in patients older than 50 years. And then there's a whole slew of other causes, familial factors, Gardner's disease. It's a little bit more common in African people. Personal history, if you have a first-degree relative who has had colorectal cancer, especially if they're under 60 years of age, even if they've had an adenomatous polyp, you have a 2 times 4-fold increased risk of developing the cancer yourself. So, and then personal history, as far as there is some cross association with ovarian, endometrial, and breast cancer. I think we're all aware of it. If you have chronic inflammatory bowel disease, ulcerative colitis more so than Crohn's disease, for longer than 10 years, you have an increased chance of developing cancer. So what are the risk factors? Well, the Cancer Agency always tells us to have a healthy lifestyle, so eat lots of vegetables, low-fat diets, be aware of your red meat consumption, and then inactivity, smoking, and alcohol. And that probably goes for a lot of other cancers as well, but definitely so with colorectal cancer. Multiple studies out there suggesting the use of chemo prevention. Aspirin is supposed to have a positive effect of reducing your risk for colorectal cancer. It has been proven with postmenopausal estrogen usage. And then vitamins and minerals such as calcium and vitamins A, C, and E. So where are they? Well, the majority are situated in the rectus sigmoid, so they are distal. That's about 50 to 60%. And then about 20 to 25% is in the ascending colon and cecum. So between those two sites, that's about sort of 70 to 85% of the cancers, with the rest then in between. So what are the screening tests for colorectal cancer, and how accurate are they? Probably still the best test is the FIT test. Now, in my first talk, I spoke about the fecal occult blood test. That has now been supplanted by the FIT, which is the fecal immunochemical test. And the reason for that is that the FIT is just, it's more reliable, it's got a higher sensitivity. Basically, the FIT test tests for an antibody to the human hemoglobin, and it does make it more sensitive for distal bleeding. More proximal bleeding, such as in the gastrointestinal of the stomach and so on, usually gets absorbed or degraded by the time it gets to the colon. So it is a good test. There are no dietary restrictions. It's safe. It's non-invasive. You don't have to use bowel preparation. It's relatively inexpensive compared to the other tests, although the FIT itself is a little bit more expensive compared to the occult blood test. It is still the best study regarding impact on mortality. So, what are the disadvantages? Well, it does have its negatives and positives, false negatives and false positives. Most cancers bleed intermittently, so you might be doing the test at the time that the cancer isn't bleeding. A lot of the adenomas, which are the precursors for colorectal cancer, don't bleed. And then there are some non-neoplastic causes, such as hemorrhoids or the anti-inflammatories, that may give you bleeding that's not from a cancer. So colonoscopy, well, that's probably the gold standard, or is the gold standard for colon evaluation. It has the highest sensitivity and specificity. It's good in the small lesions, less than 5 millimeters, which CT colonography is not as good as. And a little bit further on the talk, I'll tell you why that's not significantly important. If you've had a negative colonoscopy, you do not need any further imaging or screening for the next 10 years. Compare that to FIT test, which means you have to have it every year. So maybe it's worthwhile getting the colonoscopy and then being free for 10 years. But it has its limitations. Obviously, there's variable patient compliance. You do need to have IV sedation. When we have spoken to some of our patients coming for CT colonography who've had colonoscopy in the past, and we've asked them, well, how was your experience? How did you find it? The majority said to us, actually, we didn't mind the colonoscopy so much because we were out. We didn't know about it, whereas with the colonography, they're obviously awake. The beauty of the colonography, though, is that they can get up off the table, get in their car, and drive off. But that has been the comments that's been made to us. It is more costly. It is obviously more time-consuming. And it's incomplete in 5, and I think the surgeons here tell me it's probably more closer to 10%, which is the experience that we have here. And that's probably where I think CT colonography plays its biggest role, is in complementing the incomplete colonoscopies. And then there is an issue of localization with colonoscopy. When you're in that lumen, you're not always quite sure where in the colon you are. And they say it's about an 86% accuracy. Well, at least it's not red meat, right? So what are the causes for incomplete colonoscopy? And I think number 3 and number 5, there are what we have seen so far most commonly. Redundant bowel, that's those very tortuous loops. It's difficult for the colonoscopist to negotiate all those 180-degree turns that we have there. And severe diverticulosis, we have seen quite a number of patients with that severe diverticulosis. And then operator inexperience. Poor bowel cleansing, we have had some referrals for that, and I can tell you in our limited experience, we have found if they don't cleanse well for the colonoscopy, they don't cleanse well for the colonography either. We have the advantages that we can look at the wall, so we can see if there's an asymmetrical wall thickening. But we do want a clean bowel, and we do want a well-distended bowel. That's very important for us too. And then benign and malignant stricture. When we have a benign or malignant stricture with colonoscopy, you cannot pass it. With us, obviously, we're using just air, so we can put air quite safely to pass through it. So colonoscopy does have its complications, the least of which is perforation. That's 1 in 1,000 in diagnostic colonoscopies. The therapeutic colonoscopies, those are the ones that get biopsy, and obviously it's much higher in that. It's 1 in 500. most colonoscopies do get some kind of biopsy. If they just see that little 2 millimeter polyp or 3 or 4 millimeter polyp, they do incline to nick it off. Those are just superficial, so it probably wouldn't be fair to say that they have a 1 in 500 chance of perforation, but it is obviously higher when you do take biopsies to get perforation. You can bleed, 3 in 1,000 chance of bleeding. If the patient is on anticoagulation, it usually is stopped because of the chance that they will be doing some kind of biopsy. And then there's death is 1 in 3 in 10,000. And just a little fun fact there is that death rate from colon cancer in 50 to 50-year-olds is 1.8 in 10,000. So it's actually lower than for colonoscopy. So not that should not have that colonoscopy.
That's a 50 to 54, so it must increase after
Yeah,
that,
yeah,
right?
it does, yeah. But like I said, little fun fact. So comparison of perforation rates, because that's our biggest fear. Double contrast barium enema, I really think is now a redundant exam. I probably should have taken that out there. I'm not sure anybody is still doing the double contrast barium enema. But if you want to compare the CT colonography there at 1 to 22,000 compared to diagnostic colonoscopy at 1 in 1,000, you can see there's quite a significant difference in the perforation rates between those two studies. Obviously, therapeutic colonoscopy increases quite a bit. Flexible sigmoidoscopy still gets done. I don't think it gets done very often because it's quite a limited exam and it's just evaluation of the distal colon. So what are the guidelines? I think the question that I've been asked the most since we've started this program is, what are the indications? Why do we do them? In the US, it is advocated as a screening exam. This is not endorsed by the Canadian Gastroenterology Society, so we do not consider this as a screening exam. The FIT test and colonoscopy are the screening exams. But it is a surveillance exam, so it is an exam that can be used for follow-up. Probably the most important reason that our biggest role to play would be with number 4 and number 5 there. So incomplete colonoscopies, I think, is by far the biggest majority of referrals that we've had so far. And then patients at risk for colonoscopy. These would be patients who can't have the sedation, or patients whose anticoagulant therapy cannot be stopped, or incomplete, and older patients who can't tolerate the colonoscopy. So what are the advantages of it? Obviously, it's minimally invasive. We have a much lower complication rate, as I've already pointed out to you. We don't need sedation, which has the advantage the patient can go back to work the day if he so feels like it, whereas with colonoscopy they don't. It's usually effective where colonoscopy has been incomplete. And then we have the advantage that we can look at extraluminal structures. And I've probably got about 3 cases in the last 70 or so that we've done. I've included one here just to show you that sometimes we do pick up some useful information that can determine the next step of investigation for the patient. So what are the disadvantages? Well, it's uncomfortable. You're aware of the tube. You're aware of the insufflation, the distension. The radiation exposure, on the next slide, I'm going to talk a little bit more about that, but it is radiation. We don't deny that. It's fortunately not as much as it is. It is acceptable, but it still is radiation. We're not sensitive for polyps less than 6 millimeters, and again later on I will discuss why that is not clinically significant. But we're not good at flat lesions or the so-called carpet lesions. So we could miss those. Obviously, you can't take a biopsy and you can't remove the polyp, even if it's small. You can't do that. Accuracy depends on the expertise of the radiologist and of preparation, and that's quite important. We do need to have good pulp preparation because poop can look just like a polyp. The other thing that we need good bowel distension, which can be quite challenging in the larger patients. And then there are no outcome studies regarding the mortality prevention of colorectal cancer. So just to talk about the radiation. So the radiation there's a linear relationship between the MA and the patient dosed. The KVP is fixed. Now for a regular abdo-pelvis scan, we use about 220 milliamperes. For CT colonography, it varies between 10 to 80. We're probably closer to the 80 MA range. 10 MA is really little, and you get a very, very grainy picture. I think there's quite a significant compromise on resolution there. So we find with this sort of going towards the 80 MA range, you've got a good image, you've got good resolution, you've actually got reasonably good evaluation of your extraluminal structures as well. And as you can appreciate, that's about a third of what the radiation dose would be for a patient getting a regular CT abdomen pelvis. So that's quite a significant reduction in the amount of radiation, which is why this has now become a suitable exam for surveillance. I'm tempted to use the word screening, but I know that's wrong. It's not screening, but for surveillance. If we do have to do an exam that the patient, maybe they know that there is a colon cancer or they know there's a polyp, but they haven't been able to negotiate the rest of the bowel, so they want us to do an exam for staging at the same time, we can just up our MA and we can get both exams. So, question I get asked quite a lot is, what are the indications or what are the contraindications for CT colonography? These are the absolute contraindications. After this, I will give you the list of the relative. Pretty much most of these contraindications are reasons why we don't want to do the exam. It's not the ideal exam for routine follow-up of inflammatory bowel disease. Those patients should still be getting colonographies. We don't use it for hereditary polyposis or non-polyposis syndromes. It's not good for anal disease, and it goes without saying that we don't use it in pregnant patients. So the relative contraindications, and most of this has to do with your increased risk of perforation, as well as I think it's quite patient uncomfortable. Remember, the patient is not sedated, so if you've got acute colitis, you really do not want to have a tube and air put into that colon while you're awake. Acute diarrhea, recent acute diverticulitis. We like to be about 3 months out, or preferably even 6 months out from acute episode. I think we're still safe with doing it within 6 weeks. To be honest, I don't think we have much indication to have to do it in such a short time frame in any case. Symptomatic colon-containing hernia. I've done a few cases where we've got big hernias, we've got some large bowel loops contained within the hernia. If it's nice, big white mouth, it really doesn't matter. We get the good distension and we evaluate the colon. Obviously, we don't want a hernia that has incarcerated or strangulated. I mean, that's risky. Goes without saying, high-grade small bowel obstruction, there really is no indication for that. Recent colorectal surgery, I don't think there's much indication there. Deep biopsy or polypectomy. We do get quite a few referrals, these incomplete colonoscopies, and during the portion of the colonoscopy that was done, they did do a biopsy. We like to be 6 weeks out. If the surgeon can convince us it wasn't a very deep biopsy, we might look at 4 weeks. We try not to do it a little earlier than that, just to minimize our risk for perforation. And then obviously, if you've got colon perforation, you're not going to do it. So what does the test involve? Well, the test starts off with bowel preparation. So this is the little pamphlet that we give to the patients. It's a 24-hour preparation. It starts the day before. It starts the prior morning. They will start with their pisco salax. I can never get that pronunciation. They start with a dose that morning, and they'll have another dose in the evening. They take some barium in the morning, and they take a little barium in the evening. They are on a fluid diet, and then the evening before they get a suppository, and then the morning before the exam they get a second suppository. This is the regime that we use for patients with normal renal function. If your GFR is less than 30, we use Go Lightly. Go Lightly is, I think it's 4 liters of fluid to drink. It's not pleasant. For us, when we use Go Lightly, we get a lot of fluid retention in the colon. Now, we're lucky on our workstation, we can electronically cleanse. In other words, we can, by using the Hansfield units, we actually can clean the bowel. We can take off all that redundant fluid that we see. So that helps us quite a bit. But we prefer this technique. Obviously, got renal failure, we have no choice. We have to use the Go Lightly. Then the patient arrives here. We have them in the, we put the rectal tube in. We do We give them IV Buscopan. I have included a little list of the contraindications for Buscopan. We're lucky we can use Buscopan here. It's not FDA approved in the US. It does make quite a big difference because we do need to have good bowel distension. We can do the exam without using Buscopan. It's a little bit more uncomfortable for the patient, and we probably don't get the good distension that we want. So with a patient with a rectal tube in, we insufflate with CO2. CO2 is continuously absorbed by the colon, which is why the insufflation continues throughout the exam. We usually insufflate about 3 liters, or once we've reached equilibrium that we can see it's not insufflating anymore, to get the good distension. We do supine, we do prone. We sometimes use decubitors, especially in our larger patients, because we find once we have them prone, they're inclined to compress the bowel. So whereas if we have them lying on their sides, we get the better distension that way. So there's just a list of the Buscopan contraindications. As with anticoagulant therapy, you don't want to stop if the patient has a myocardial infarction within the past 6 months. We wouldn't want to use Buscopan in those patients either, but that doesn't mean we can't do the exam. It just means we don't use the Buscopan. The most important contraindication for us is tachycardia, so we do have the patient monitored while we do the exam. We do have them connected to the ECG, and we do monitor them after the exam for about half an hour just to make sure that we're fine. And then the other causes, myasthenia gravis, untreated narrow angular glaucoma. Now the glaucoma, I did read up about that, because if it's untreated, then you don't know you've got it, and that's a whole issue, is these patients don't know you've got it. It's not a contraindication per se, because it can be treated. If the patient does develop acute narrow angle glaucoma, which statistically is very rare, it can be treated and it should be fine. So the primary goal of CT colonography, as of the other screening techniques, is to detect the precursor lesion of colorectal malignancy, and that lesion is the adenoma. So basically 4 types of adenoma: the benign neoplastic, which is the adenoma, and then the non-neoplastics, which is hyperplastic, inflammatory, and hematomatous. And we're not worried about those last 3 because they do not become malignant. But the adenomas do have the potential for malignancy. Only 3% of adenomas will progress to malignancy, but 30 to 40% of people by the age of 60 years will have an adenoma. So the types of adenomatous polyps that we're looking at, they get graded according to their dysplasia. So mild, moderate, or severe grade of dysplasia. And then there are the 3 histological types. The tubular adenoma, which are usually the small ones. These are the ones that we don't usually see less than 5 millimeters. Fortunately, those are the vast majority. 85% of them are the tubular adenomas. Then we get the in-between, the tubular villus. There's about 10% of the adenomas. They're usually more than 10 millimeters, so these are the ones we want to catch. And then the big ones, the villus adenomas, fortunately only 5%, but they have a significantly increased risk of developing malignancy, more than 10 times, and 75% of them are more than 2 centimeters. So they're the ones that are much easier to see. 2 centimeter lesion would not be difficult to overlook. So the adenoma-carcinoma pathway, as you could realize there, the bigger the polyp is, the higher the incidence that this will be malignant. And if the polyp is less than 5 millimeters, if the polyp is between 6 and 9 millimeters, it's a less than 1% chance of malignancy. If it's 10 to 20 millimeters, it's 10%. And if it's more than 20 millimeters, it goes up to almost 50% malignant chance. So what are the recommendations based on that information? Obviously, a polyp bigger than 10 millimeters and definitely bigger than 20 millimeters will proceed to colonoscopy. I have asked the surgeons, what if we've done the CT colonography because of an incomplete colonoscopy and now we find this lesion, now what do we do? The answer was they will repeat the colonoscopy. They say sometimes on the day you cannot get through that bowel. but sometimes on another day you can. So even though they've had an incomplete colonoscopy, they will, knowing that there is a lesion, they will go back. Sometimes somebody else will do it, just a different hand, or they will go back and see if they can get to that lesion. If the polyp is between 6 and 9 millimeters, we suggest doing a follow-up CT colonography in 3 years, because that has a less than 1% chance of cancer risk. If we find 3 polyps in the 6 to 9 millimeter range, that is the same risk as having 1 polyp of 10 millimeters. So we would suggest doing colonoscopy. Okay. If the polyp is less than 5 millimeters, in fact, we're told actually not to report them. And that's why in my reports you'll see I will say no polyps identified more than 6 millimeters. In other words, there might be a polyp of less than 5 millimeters, but we're not worried about those because your chance of getting cancer is less than 1%, 0.1%. So it's significantly less. So that's probably the most important slide of the whole discussion, is just so that's what the interpretation involves. More than 10 millimeters, colonoscopy, 6 to 9 millimeters, follow-up in 3 years, less than 6 millimeters, we don't worry. So just to show a few cases, most of these I did take off the internet. I have got a few at the end that are of our own little library. So this is a pedunculated tubular villus adenoma, and that's on your left is the endoluminal view. You can see a nice photo of this little stalk with a little polyp sitting on it, and on the 2D view, there we go, not even using that, we can see that little pedunculated polyp nicely outlined by the air there. So this is a tubular villus adenoma, and you can compare what our image looks like, adenoma sitting there on the fold, and that is the endoscopic view right next to it, and you can see the two compare actually quite favorably. And I think this one was more than 2 centimeters, so that's why they went for it. So this is, again, quite a sizable mass here. Here we've got the 3 different views. On your left is the 3D or the endoluminal view, which is a nice picture. As a radiologist, I like the one in the middle. That's the 2D view. You can see this lobulated sessile mass. You can notice the little bit of barium coating. So we use this fecal tagging or barium tagging as an aid to diagnose these. Firstly, the barium will always sort of sits on the outline of the mass. If it is feces, the barium is often included in the mass. So you can see, if you can see barium within the mass, you know, or air, you know, this is fecal material compared to when it outlines it, as you see nicely in this case. And this was another villus adenoma. This is another malignant polyp, just the endoluminal view. So this is a image of a cancer. You can see on your left there, you can see that apple core lesion. You can see the asymmetrical wall thickening. You can see that narrowed lumen. You can see the shouldering that the tumor gives. And then on the right is the endoscopic view. You can see the almost circumferential annular mass sitting there. And I would think that's probably in the sigmoid colon. This is just a hyperplastic polyp, 7 millimeters. We would suggest colonoscopy in 3 years follow-up. Obviously, they went and did colonoscopy at the same time, and it's just a benign polyp. That's what hemorrhoids look like. So that's the tube, and you can see the hemorrhoids around the tube at the base. I included this slide because diverticulosis is something we see almost on a daily basis. And this is just to show you what the difference in the appearance is of a diverticulum compared to an adenoma. The diverticulum has a sort of an outward projection, and you can see that sort of dark rim surrounding it, compared to the adenoma on your left, which is more an inward projection. You can see the mass protruding into the lumen. So the last 3 cases are cases of our own little library. This is a patient who had a colonoscopy, and the surgeon came and said to me, I got to the distal or the proximal portion of the ascending colon. I couldn't quite get to the cecum, but in the distance I could see a little mass. He could just see the tip of it. So we went and did the colonography, and sure enough, there, right at the tip of the cecum, was this lobulated invasive mass. That's the 2D view on your left, and on the right is the 3D endoluminal view. And this was a locally invasive, fortunately low-grade adenocarcinoma.
So did they then try and repeat the
No,
colonoscopy, or
no.
they just went right to surgery?
Yeah, they went right to surgery, and that was the histology. Yeah. Well, he was pretty sure he saw, he just got a glimpse of it. He showed me the photo. You could just see the tip of it.
Yeah.
And yeah. This case, unfortunately, I don't have follow-up on it yet. This was a patient who had a positive FIT test, had quite bad diverticulosis, couldn't get through with the colonoscopy. And I think the scope got probably to almost 10 centimeters from this lesion, so quite close. But here we have this large, more than 2 centimeter pedunculated polyp, which I would be confident says probably a villus adenoma. And I'm sure this guy will progress to surgery. If not so, he might have been done by the coast, I'm not sure, but we didn't have follow-up on that. And then the last slide I have for you is just to show you that sometimes we don't get a good CT colonography, but we do get other reasons why we can have explain the patient's ongoing anemia. So this was an elderly patient who had anemia. Colonoscopy was incomplete. We did the colonography. It wasn't the best exam. I think it was good enough to say that she doesn't have a colon malignancy. But here, there we go. But when we did the exam, we did see that she's got sort of multiple, this was just one image, but multiple hepatic hypodensities. She had a lot of these peritoneal masses, peritoneal implants. And I did question the terminal ileum. You can see the terminal ileum there. It's sort of circumferential wall thickening, a little bit of stranding around it. So I was venturing to say that I think she probably has got a terminal ileum malignancy with, unfortunately, already metastatic disease, multiple hepatic metastases, and peritoneal carcinomatosis.
Now, would you get that image?
This was on our
CT?
This was our CT colonography.
Okay.
She did progress to have a formal
CT,
study.
yeah.
But I think just on our images, you get a lot of information.
Yeah.
I do have a few other cases of where we did a CT colonography, and when we looked at the lung windows at the bases of the lung fields, you could actually see metastases. So another case that we could say patient has already got significant other extraluminal findings. Yeah. Okay, anybody for questions?
Hi, it's Chuck Burkholder here in New Denver. Is there any potential for this technique to be used for the entire bowel, like to replace a capsule endoscopy in those GI bleeds that are no sources found in the upper and lower scopes?
Actually, at the moment, we've already started to do CT enterography. It's a reasonably uncomplicated exam. The patient just has some, we give them a certain sort of a dose of barium, I think of 2 hours before the exam. So yes, your answer is yes. It's not the CT colonography that we're doing, so we don't do it from distal insufflation, but we are doing a prograde as a CT enterography. Okay, is anybody else? Well, then I think we're done.
So it's Keith Merritt from Castlegar. So the FIT test is recommended every 2 years, not every year?
Oh, okay. 2 years. I read a year.
I think it's 2 years.
It is.
And
okay.
One advantage to the FIT test is that it's only have to do once rather than 3 samples. So I think the compliance for FIT testing is better.
Yeah.
So right at the moment, do you think most of your referrals for CT colonography come from the surgeons and not us?
Yes. Yes. Katie refers over there, but definitely the majority of referrals so far have come from the surgeons.
But you don't need to do it, I guess. Understanding as a GP is they have a colonoscopy and it's clear. You don't have to do anything for 10 years.
For 10 years,
so that
yeah.
includes the FIT test too.
Yes.
So
yes.
yeah.
Yeah.
So that's
yeah.
But
So
you
it's
have
still
the same benefit if you go through her. right?
Yes,
If
the
I
same
can do
thing.
Colonography,
Yeah,
they have
and it's
10
negative.
years.
It's
So
10
depending
years.
on my high-risk patients, I've sent a few to
Yeah,
her already.
yeah, yeah. So that's why it still is the gold standard.
Yes.
I was telling Katie before the presentation started, when I did the course, the people at the course said when they started with CT colonography, they offered it for free, obviously this being US, to any of the staff in the hospital, and almost nobody came. People don't want to do the exams.
No.
I mean, they don't want to do the poop sampling. They don't want to come for the colonoscopy. I mean, I'm 52. I haven't been. So
The prep is
Yeah.
huge. It's
Yes.
you know, at least this one's a 1-day prep
Yes.
compared to the colonoscopy is 2 days.
yes,
So that's a little bit easier, and that's
Easier.
good to know too.
Yeah,
Because 2
yeah.
days is really rough.
it is rough.
Yeah.
Yeah. I found even with the 1-day prep, at one time with scheduling, we were trying to schedule some of these patients at 12 o'clock at noon, and that just didn't work. We had 2 patients that were quite hypoglycemic by the time it was 12 o'clock.
Yeah.
So now we have shifted it back to doing it at 8 in the morning.
Yeah.
Yeah.
Again,
Yeah,
Keith,
she'll just need to emerge someone that's
Hypoglycemia
has their prep and then they
Oh,
wind
really?
up.
in there.
Yeah.
so again, Keith Merritt, what's the wait time for this, and how long does it actually take to do the procedure?
Oh, the procedure is real quick. Probably 10, 15 minutes. Patients basically just on the table. We inject the buscopan, we insufflate them. That takes about 10, 15 minutes, and to scan through takes a minute either side, supine prone. So it's a real quick exam. We usually book the patients, I think, per half hour, per 45 minutes, but that's more for the monitoring. As far as the wait time is concerned, well, I think we're at about 4 or 6 weeks now, and that has to do with scheduling. The techs, most of them are trained. We have 1 or 2 that need to get the training. At the moment, I'm the only person that's doing this. Gonzo is going for it's booked, it's paid. He's going in May. So by when Gonzo gets back, I think it will be less of a problem. We are looking at doing this over weekends. So although we're at a 4 to 6 week wait time now, I hope that not too long from now we will be down to 1 or 2 weeks.
Hi, it's Tyre in Nelson. Oh, sorry. This is too high tech for me. I was just concerned about the recommendation from the BCCA to not do fit testing after colonoscopy, and colonoscopy again in 10 years, given the 5%, lack of false negatives. And I just think to do a fit test again, maybe even in 3 years, would be just a little bit of a safety net. Do you have any thoughts on that?
I guess no harm done. I mean, the recommendation is that you don't, if you've got a negative colonography or colonoscopy, you don't need to do testing for 10 years. I think part of that has to do with the size of the polyp. I think you need to have a polyp statistically larger than 10 millimeters probably for a significant increased risk of developing cancer. And I guess in that 10-year period, your chance of developing that polyp to that size is within acceptable limits.
Right.
But again, no harm done. If you feel more comfortable doing a fit test every 3 years or every 5 years, I would go ahead.
Yeah. Okay, thanks.
Hi, Elsabee, another question here, Nelson. Just wondering, it's Dharma here. Just wondering how often you're seeing CT colonography recommended for, or proposed for someone who's clinically, let's say the elderly patient who clinically they've got a colon cancer, anemic, etc. They don't want to have a colonoscopy, but they want closure on the whole process to see if there is actually a mass there.
We do have such referral. I know we've got one person who's pending, 85-year-old. He's not an operative candidate, got fresh blood per rectum, apparently actively bleeding, and they do want to have closure. They do want to know where the cancer is and how big it is. I mean, you're tempted to say, why bother? He's got bad COPD, but that's what the patients want, and if they're comfortable with doing the procedure, yes. The other referral that we have seen is patients who can't stop the anticoagulation therapy. We've had a few patients in that category as well. But yes, we do get those referrals.
Elsabee, is there any chance you could email the slides to us, or maybe to Jamie?
There's 100% chance I can do that.